Many of you have heard a lot about PrEP in the last couple of months and years, so bear with me if some of it is repetitive, but sometimes it takes repetition for us to think through it again, know what to do, because I don't think we have the answers yet, and I don't think we know what we should be doing. The pills are there, and that boy wants to know why we're not using them. And given the data we listened to this morning, we still have an epidemic that we haven't resolved. So I work at the Kenya Medical Research Institute, and I work with colleagues at the University of Washington, and I do PrEP prevention research. So I'll take you through the journey. A lot of data many of you have followed, from the proof of concept studies to the scale-up projects. Some of the data which was presented in CROI this year on population level impact, some of the rollout, and I'll show you some slides from our work in Kenya in PrEP scale-up, and some of the work in the pipeline. And then there'll be a session later today. I'd encourage everybody. There's a debate about provision of PrEP in clinical trials that we should all attend. So the journey of PrEP started way back in 2010, where we had the pivotal MSM trials. And I think people went to IAS in Vienna, celebrated the first results of an efficacious intervention. This was followed up with our HIV serodiscordance studies and the FDA approvals. Then we had WHO guidelines, nation guidelines, and a whole movement now moving towards scale-up and the Large Dreams program, which many countries, I think, in the audience are implementing. So we know that the recommendation for oral PrEP sits on the backbone of very strong scientific evidence. It's also delightful, actually, to realize when we looked at the demonstration project data that, unlike what is usual, the impact, the effectiveness from PrEP demonstration projects was much higher than clinical trials. Once people knew it worked, it looked like they used it much better. So amongst MSMs, they moved from an efficacy of 44 to an effectiveness of 86, and this was the same in IPAGE and other trials that have followed up. I won't list them all. In our own trials, Partners PrEP with serodiscordant couples, our clinical trial data showed an efficacy of 75, and demonstration project, I will show you the slide, showed almost near elimination of HIV, combining PrEP and prevention. So we did some other sub-analysis, and where people actually took the product, efficaciousness was even higher, almost 90%. Some of our colleagues reanalyzed the data, and they looked at women and men with STIs, with partners with high viral loads, in MSM cohorts where they didn't use condoms, and we're still able to demonstrate that this product worked really well when the tablet was swallowed. So I think the data on men is clear and nobody questions it. And this is the data from the Partners PrEP study. I think many people in the audience have seen it before, but I'm happy to show it to you again. In the Partners demonstration project, we provided PrEP for 6 months while the partner was on treatment for viral suppression. So it's a very short spurt of PrEP. Some people took it longer than the 6 months because not every person on treatment will initiate treatment even when it's available. And in that cohort, we only observed 4 infections compared to what we expected of 83. And out of these 4, the majority either didn't take their care and treatment, didn't take PrEP. So we were very pleased with those results. We were also very pleased to recognize the synergy between treatment and pre-exposure prophylaxis. I think early in the field, there was a lot of controversy, like there could be competition between the two products. We know that it's important to treat, and there's no question about it, and treatment is prevention. But PrEP and working with HIV at-risk people increases testing. It also gives us more cases of people who we wouldn't have known are infected because they now have an option for care and treatment. So it reduces the number of people who are undetected in the community. There's a lot of work that has happened as the PrEP trials were done, because there was a lot that we needed to know as we moved to scale up. We just heard from Dr. Kirago, that young adolescent women are at very high risk, and this is across globally, and it's around the age of reproductive age. So if people get pregnant, you want to know that the products are safe, and we're not about to stop people getting pregnant. We want to know how to deliver. Can people use it in breastfeeding? Is it cost-effective? Is it safe? Will people stop using condoms? Would there be resistance, and would people be interested? And one of the elephants, as one of my colleagues likes to say, is the issue of adherence. And what was clear across our trials is in the trials where there was high adherence, as was demonstrated in plasma, there was also very high efficacy. And unfortunately, in the women trials with less adherence, there was less efficacy. There was sub-analysis done because the question kept being asked, does PrEP work in women? But we have been able to show that indeed PrEP works in women effectively, and that the Botswana trial, which didn't have serodiscordant couples, was also able to demonstrate efficacy, and injection drug users in Bangkok. So what we've learned is that it's safe, it's tolerated, and the side effects which are seen of bone density are clinically not toxic, and that it's safe for reproductive. For men, there's no change in their sperm counts. For pregnancy, it doesn't interfere with it, and it doesn't interfere with our ability to use contraceptives. That the resistant data is reassuring because when you have the product in you, you don't get HIV infection. And if you don't use it and you get HIV, very often it's because you don't have the product in it. So this data assured us that it was time to move from clinical trials to delivery of PrEP. So early this year, and I think earlier than that, we started seeing data on population impact. And in San Francisco, where they have large cohorts of MSM, they've been able to demonstrate up to 51% reduction of HIV infections between 2010 and 2016. And it's not all PrEP. I think it's important to recognize that none of these interventions work alone, that they increase PrEP access, but they also worked along with same-day ART and with the community working cohesively together to deliver service, to be able to define their risk populations, and to be able to reach, I saw the slides today from Rwanda, where there's very clear definition of what the target population looks like, so you know when you're reaching success. More recently, we also received data from Australia, CROI this year, and it's part of it is published, showing 25% reduction of HIV infection from the time they started targeted delivery of PrEP amongst men who have sex with men. In the UK, they didn't have a national program, but people started buying PrEP online and were able to show a 42% decline in incident infection in their clinics. So public health impact will come, but it will walk along coverage. It cannot be sporadic delivery. We need to do population-level implementation to be able to really get to the success. I think this morning we heard quite a bit about youth and young women, and I didn't want to ignore this population, so you'll bear with me. And this slide reminds us that while we've had success in pediatric reduction of new infections and in adult infections, we continue seeing increased numbers of people ages 15 to 24 with HIV infection. Some of it is said to be from the youth bulge, that we're having a huge number of young people, therefore the sheer numbers may very well overwhelm us. And we can see from this slide that we have 7,000 new HIV infections every week in young women all over the world, and that our regions, as we were shown in South and East Africa, take the bulk of that burden. And 2 of 3 new infections of women come from our region. Now, there are multiple reasons why women are vulnerable, and PrEP will not take care of these reasons. And I think that's why we'll keep saying that prevention must be holistic, and we must look to the other things that drive vulnerability. The question of whether PrEP works in young women, we have data to show that it works. And even amongst the trials where it wasn't efficacious, sub-analysis was able to demonstrate that it works. So though we can't target all vulnerabilities with PrEP, but I think it's a product that we need to give. So there have been various studies which are ongoing to look at these issues, to understand why young women didn't use PrEP or why they didn't adhere. So I'd encourage you to look out for the data from these various trials. As I move on to look at the question of what is effective implementation. And you have to have a clear framework and what you define as your expectation. What do you target? Your demand creation messaging, I'll show you some very innovative messages that have been developed. In our trials of PrEP scale-up in Kenya, we found champions to be wonderful. I think Rwanda is blessed with a first lady who's been a great champion of reproductive health, and today we saw the impact of championship. You need to have the right tools to work with, and you need to make it simple for people to use products. Even healthcare providers don't want complicated interventions. I think you remember when treatment was complicated with different CD4 counts, it made it very difficult for people to use. So we need to engage populations who we want to reach, so we need to know who it is, we need to engage them, it needs to be simple, and we need to learn from people who start using. So there's a lot which is done from social media, and you see from most of these adverts that it shows happy people. It's not talking about risks. It's talking about better life, about being empowered. I'm my own woman. This is my moment. I'm prepared. I own my sexuality. It's like the contraceptive pill, so it's doable, it's personal. It's for me and it will work. And those are the tools that have been shown to work. People don't want to be called at risk. Young people don't want to be labeled, and I think most of us don't want to be labeled. So I've moved rather quickly, but I'll still go there. WHO's done a tremendous job in developing tools for PrEP implementation. I encourage you to look those up, and they very holistic, looking at all areas of delivery. In Kenya, for our trial, we also developed a one-pager for healthcare providers, so it's not complicated for them to determine who should get PrEP and how to document it for information collection. We've also worked on minimizing, the requirements. So we don't necessarily, we recommend creatinine, but we don't require it. And all this is working well for delivery. So we need to get these products in people's shoes, not in people's shoes. So we need to find the products that people will use. And I know I listened to somebody's presentation, and they say, you may have the right shoe, but without a sole, you can't use it. So we need prevention approaches that are not stigmatizing, can be used easily, are desirable. And we now have a wider array in research to give people options for their prevention interventions. I think there's a lot of work on cabotegravir. They've done the phase 1 trials, phase 2 trials, and currently you should watch out for the data on phase 3 trials. I know people in the treatment world are also very excited about long-term injectables. There's talk about 1 tablet a month, and science is even thinking about giving long-term implants. So PrEP has changed the arena and the field and the options. There's a lot of work that's been done on intravaginal rings. I think from 2016, we had the results from the ring study and Aspire. And what's really encouraging are the results this year during CROI, when both teams told us that from their follow-up cohorts, there's increased prevention amongst young women now that they knew that the rings worked well. We have ongoing multi-purpose technology work, which have almost all gone through phase 1 trials, combined products of levonorgestrone and dapivirine, tenofovir and levonorgestrone. So look out for much more. So now I'll move very quickly to what we are doing in Kenya, because I'd be remiss not to talk to you about my own country. So we've worked hard, or the national program has worked very hard to move to PrEP scale-up nationally. And it's been driven by the National AIDS Control Program in cohesiveness with delivery partners. We've had policies in place, delivery considerations were put in, demand creation, and structures for monitoring and evaluations. Right from the Kenya Strategic Plan, PrEP was put in there, and they made guidelines that gave people guidance. Even when nationally we didn't have money for delivery, it was recognized that it was important that we tell people how it should be done in a uniform way. So we had a large launch last year led by the ministry, and that's our Director of Medical Services. And in delivery, there was a prioritization of geography so as not to stigmatize. The work started in geographies where they have high HIV burden by programs. And that's just to show the framework and implementation model. I'm just trying not to take too much time. So it's gradual. It's not a huge, it's not a rocket to the sky. You don't give PrEP and they all take it. It takes time for communities to accept, for people to say, I used it, I liked it, it was safe. I had a bit of diarrhea, it didn't trouble me too much. But it's also reassuring to look at the US data, to see that it started slow, and then it hits a certain point, and it starts rising in the number of people who collectively are willing and interested in using this product for prevention. So some of the things and considerations we've had is to have a nurse-led model. I know there's a lot of discussion about PrEP on community-level delivery, but a lot of work is starting off with healthcare providers because of the prescription issue and the testing issue. That it's integrated into services. It's not a standalone service anywhere. Most places, it's going on either in the HIV care clinic, in diocese where MSMs may go to, or sex workers are seen. And then we're not working too hard to be stuck on the issues of risk score. And though initially, there's a drop at month 1, we know it will take time for people to continue using the product. So selecting PrEP eligibility may be useful, but I think when you look at the demonstration projects and many other profiles, people are able to self-select well. So we don't have to worry as much as we worried before that would have a lot of worried well using expensive products when they don't need it. I just want to say that beyond prevention, that PrEP has re-energized our combination prevention agenda. It has re-energized advocacy for prevention. Even as we commenced PrEP, we recognized that there wasn't a place where prevention happened. People went for testing and that was the end of it. There was no follow-up or longitudinal care for people who were not infected. And for women, they needed a controlled, discrete method, and it added protection for sex workers, and it's adding something to contraceptives. So the POWER study, I didn't go into that detail, maybe in the sessions today somebody else might talk about it, is introducing PrEP in family planning clinics. And one of the things I've heard from that team is that they're seeing up to 30% treatable STIs, and those were things we were not paying attention to. Issues of men who have sex with men, it has also inspired activism. For serodiscordant couples, they have safer conception options. And for the general population, there's increased testing, and in some areas, Hep B vaccination. And we have peers and lay person workers who are empowering themselves beyond just the PrEP work they're doing. So there's skepticism in the field, and I think that's acceptable. It keeps everybody in their feet, and it makes us improve what we need to do better. What's working well is global leadership, national uptake, and having a strong public health agenda, and a uniformity from UNAIDS, WHO, and country-specific guidelines access. So again, I'll repeat, I encourage you to come to the 445 debate. But the question I want to leave you with is, do we have anything to lose if we don't scale up PrEP? And how will history judge us? So nothing's perfect, but a glass half full, I think, is always better. So I want to say thank you, asanteni sana, to colleagues who shared their slides, to all of you, other scientists in the fields, and the funders who make this work possible. Thank you.